Well, good afternoon, ladies and gentlemen, and a warm welcome from a cool Cape Town. My name is Peter de Jong. I'm co-host this evening with Professor Steve Jeffrey. We are very, very privileged to have Dr. Jireh Serfontein. She works in Die Wilgers, which is in Pretoria, or Tshwane as we sometimes call it, and she's going to be speaking about sexual health function after breast cancer. Dr. Jireh Serfontein, in fact, is a person that's been with my sexual health team for more than 10 years. We've had them on before, many a time. And she's an expert on STIs, HIV, and sexual dysfunction of all shades and colors. So she's speaking about sexual function after breast cancer. We haven't had this talk before, so we're listening. You're going to hear very, very keenly what she's going to say this afternoon. And next week, we have Professor Barry Jacobson. He's on the same platform. He's going to be speaking about air travel in pregnancy. Should you fly or should you not fly during pregnancy, Steve? And then we don't have a sponsor, do we, Chris? So I'd like to thank the Pelvic Floor Foundation for being the sponsor this afternoon. It's been very kind of them to outfit this. And without further waste of time, Dr. Jireh Serfontein, sexual function after breast cancer.
Thank you so much for the kind introduction. I'm excited to be here. So I'm just quickly going to share my screen and then we can get going. Okay, cool. So I just want to double check that you guys can see my slides and everything is the way it should be.
We can certainly see your slides. Would you like to make it full screen, Dr. Serfontein?
Is it not? How do I do that? Well, I just shared my screen. Are you seeing the presenter view or?
Yeah.
Yes.
Yeah, yeah, so
Hold on a second. Cool.
I don't mind. I mean, the presenter's very viewable, so we don't have any problems about the view. But if you could make it a bit bigger, then you don't have to look at Steve.
No, of course, I checked this and hold on a second now. This thing is giving
What about
me
that green button, Steve? Isn't that the one you press?
No, it's just a normal PowerPoint
There you go.
setting.
No,
There you would
that's
normally
you.
go to that says view presentation or something like that. Just a normal.
Okay, so it's going to
We
say
just
from
do
the
the-
beginning here.
Yeah, that's it. Yeah, but now we can't see the
Slides anymore.
yeah. now you
Okay, hold on a second.
again.
Oh, look, it doesn't matter if it's the presenter's view.
But-
Really does, because we can see quite nicely.
But what are you seeing on your end?
We're
No.
seeing you.
You need to share your screen again, and then you can just go to the normal PowerPoint setting to view presentation, and then.
Oh, did I stop sharing? Sorry, now I'm wasting time.
No. We're very informal this evening. There's no. Just to remind you, while you're doing that we got FIGO coming up, Steve. That's in October in Cape Town. We've got a few more days of the special rates. So if you want the early bird rate, you got 1 week before the early bird rate is taken off the table. So I'd like to commend everybody to go onto the FIGO, F-I-G-O. There we go. That's it. That's perfect.
Great.
Dr. Jireh Serfontein, sexual function after breast cancer in patients.
Perfect. Okay, so just a quick introduction. So breast cancer is the most common cancer in the world, affecting women. And in the year 2020, we had more than 2.2 million women diagnosed with breast cancer. Just looking at South African stats, breast cancer is definitely the #1 cancer that affect women. That's followed by cervical cancer, colorectal cancer, uterine cancer, and lung cancer. And just touching on the guys, prostate cancer is the #1 cancer affecting men. And I know we're talking about sexual function post breast cancer, but just thinking about pelvic health and the way cancer can affect pelvic health, it just shows you that breast cancer itself, and we'll go through that tonight, is definitely affect sexual function, cervical cancer, colorectal cancer, and uterine cancer. The treatment involves radiotherapy of the pelvic area. And then for the men, prostate cancer can also result in pelvic radiation affecting sexual function. So unfortunately, the stats speak for itself. It's very common for South Africans to get a diagnosis of cancer, and we will focus on breast cancer. So the overall 5-year relative survival rate for breast cancer is 90%. And with means of which means that 90 out of 100 women are alive 5 years after they've been diagnosed with breast cancer. And the 10-year breast cancer survival rates are as high as 84%. And these survival rates gets determined by the type of cancer, the stage of the cancer, the grade of the cancer, as well as other details of the cancer, such as the amount of DNA in them, whether they have hormonal receptors, gene expression test results also play a role in survival rates, age of the patient, overall health, and how the cancer actually responds to treatment. And looking at the treatment options, treatment of early breast cancer relies on the combination of chemotherapy, surgical intervention, which would be mastectomy, and radiation therapy. And all these treatments have side effects or sequelae identified as high risk factors for the development of female sexual dysfunction. So why is it important to talk about sexual function in breast cancer? Firstly, because of the high survival rates, patients live, so it's not a death sentence, and sex matters. So we want to focus on quality of life and improve sexual function in general. And this was an interesting study that I came across. It was a longitudinal study, a systemic review. The incidence of sexual dysfunctions ranged from 30 to 80% in women diagnosed with cancer, while the risk of developing sexual dysfunction increased 2.7 to 3.5-fold in women with cervical or breast cancer. And the conclusion there is that different cancer treatments increase the risk of developing sexual dysfunction in women, especially desire, arousal, and orgasm, leading to psychosocial changes. And the most common female sexual dysfunction that they found was a decrease in desire, arousal, as well as orgasm. And the most common presenting symptom for these ladies were dyspareunia, vaginal stenosis, menopausal symptoms, depression, fecal incontinence, abdominal pain, and pelvic symptoms. And out of the 16 studies, 9 studies reported that cancer treatment itself affected sexual function. So it's not only the diagnosis of the cancer, but the treatment also. So what is sexual health? The World Health Organization defines sexual health as a state of physical, mental, and social well-being in relation to sexuality. It requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, free of discrimination, and free of violence. And this is a beautiful definition for me because really it focuses on pleasurable sex as well. And it just shows us that everything in life and looking at a patient holistically, it's about physical, mental, and social well-being. And the other key point for me here is free of coercion, free of discrimination, and free of violence. So discrimination also just tells me that we can't discriminate against a patient thinking that this is a lady of 80 and she's been diagnosed with breast cancer, and we make assumption that she's not sexually active, and the older we get, sex is not important anymore. So we don't want to discriminate based on patient's age, patient's sexual orientation, ethnicity, or anything like that. This was just a new definition that I thought is also very, it's just a beautiful explanation, a definition of sex. So sex can also be defined as a sexually pleasurable activity affectionately shared amongst equals. So before one can define abnormalities or make a diagnosis of a sexual dysfunction, we need to understand what normal sexual function looks like. And this was the first research done by Masters and Johnson in the 1960s. And they came up with this linear model saying that there's distinct stages. So we've got excitement, that's followed by a plateau phase. And as sexual stimulation continues, that plateau phase will eventually build up into a climax. And then we've got a resolution. So the excitement for men is obviously erection, and for women that is lubrication, genital swelling, and then obviously just the general feeling of being excited. The problem with this model, however, was that they didn't describe desire or libido. So it was in the 1970s that Helen Kaplan came up with this model, also a linear approach, but she said we need to talk about desire, and she placed desire as the starting point, and that would be followed by excitement and orgasm. The problem with that is that desire is not always spontaneous. And then in 2001, Rosemary Basson came up with this model, and it is very complicated. It looks very complicated, and just everyone just tongue in the cheek always says that men are so simple and eenvoudig when it comes to sex, and women are very complicated. But I'm just going to break it down for you. So we've got a spontaneous desire, and then we've got something we talk about as a responsive desire. So looking at the top of the screen, you'll see there's a willingness to become receptive. So if you are willing to become receptive, you will allow sexual stimulation in an appropriate context. And then if psychological and biological processes are in place, that will lead to subjective arousal. And once there's arousal, we develop a responsive desire. And that then is followed by having a satisfying sexual experience with or without an orgasm. And that can motivate you to be willing the next time to open up for sex again. And the other benefits of a positive sexual experience is that it's not only sexual rewards that we see. There's emotional intimacy, there's well-being, and a lack of negative effects from sexual avoidance. So just to make it just an easy example that I often use is chocolate. So I love chocolate. I'm a big chocoholic, but I don't think about chocolate 24/7. So I don't always have a spontaneous desire to eat chocolate. But if my husband comes home late at night and he said, okay, listen, I bought you a slab of chocolates. It's your favorite, take a bite. And I'm already in bed, I brushed my teeth, and chocolate is the last thing that I want to have right now. And I see his droopy eyes and I feel sorry for all the trouble he went through. And it's like, okay, fine, I'll have a bite. And as I bite down into that chocolate and I actually experience it, and then I feel actually excited about the chocolate, I'm like, okay, now I didn't think I'm in the mood, but now that there's experience, I'm going to just finish the whole slab. And that is what sexual desire looks like for most women. So most women really have to rely on that responsive desire. The other model that is very relevant and that was published in 2006 is the dual control model. And the interesting thing there for me was that it focuses on psychological things, cultural and behavioral issues, but also physiological things. So it says that we've got sexual function has got this waiting for this tipping point. It's a seesaw. On the one side, we've got excitement, and the other side, we've got inhibiting factors. And from a physiological aspect, inhibiting things could be neurotransmitters such as dopamine, noradrenaline, oxytocin, vasopressin, and then excitement. Actually, sorry, I flipped it around. It's slides are wrong. So excitement is dopamine, noradrenaline, oxytocin, melanocortins, and then vasopressin. And the inhibiting things would be serotonin, opioids, and prolactin. And we want to have a tipping point, and we actually want to be quite stable 24/7, because if we don't have any inhibiting factors, people will just randomly masturbate in public, and that would just be bizarre. So we want a balance between excitement and inhibitions. But the problem with sexual dysfunction is we can't take our foot off the brakes. The inhibitions are too high, and then we don't respond to the excitement. So looking at this dual control model, the inhibiting factors we can also describe as having brakes on, and things like biological factors, social relationship issues, psychological and cultural and religious things can also play a role there. So the inhibiting factors from a biological point of view could be a lack of estrogen, it could be a lack of testosterone, recurring infections, chronic diseases, medications, or surgery and radiotherapy. Then from a social side, things could be relationship issues or partner or relationship problems, partner sexual problems, lack of stimulation, lack of intimacy, lack of privacy, or just problems talking about sex. Psychologically, depression, anxiety, body image, distractions, and cultural and religious factors. It could be a strict, restrictive sexual morals, no sexual education, the idea that sex is only to have children, in general, cultural suppression of women, and female genital mutilation is luckily something we don't see in South Africa very commonly. But just getting back to breast cancer, from a biological aspect, there is the lack of estrogen because we use estrogen blockage. We also see a block of testosterone then. Just the chemotherapy itself can make you feel terrible. And because of that, there's a problem with sexual dysfunction. The social things, it can have effects on the relationship. Psychologically, having a diagnosis of cancer can result in depression and anxiety. Getting a mastectomy done can result in body image problems. And then culturally as well, we need to take that into consideration. So just looking at female sexual dysfunction, this is just a classification of the things that we see. So if there's problems with desire, we get hyperactive sexual desire disorder or just low libido. It's the most common thing that I actually see in my practice. Sexual aversion disorder, if there's problems with arousal, we talk about female sexual arousal disorders. If there's problems with orgasm, female orgasmic disorders, and disorders of sexual pain would be dyspareunia and vaginismus. So here's just a case study. It is a 39-year-old female, and she's Muslim. She got married in 2006, and she was unable to consummate her marriage. She was subsequently diagnosed with vaginismus and received treatment over many years. Eventually, 10 years later, they consummated the marriage and they had 2 children. Unfortunately, later in life, she got diagnosed with colorectal cancer as well as triple negative breast cancer. And she was referred by a gynecologist. It was impossible to do a pap smear. Sex was impossible again. She experienced bleeding when they attempted intercourse. She had no desire, arousal, or orgasm. And the female sexual function index, which is a validated questionnaire that we give our patients to complete, was under 24, saying that she's got severe sexual dysfunction, termed global sexual dysfunction. So when we examined this patient, we saw that there's severe atrophy of the vulva and narrowing of the introitus. She had allodynia, 8 out of 10, all around the vaginal opening. She had significant muscle spasms. The pelvic floor was hypertonic, and we could actually not insert a finger into the vagina. And she had significant vaginismus behavior, grade 4 vaginismus, almost avoiding a pelvic examination. So she was diagnosed with secondary provoked vestibulodynia, the neuroproliferative type, due to hormonal deficiency, grade 4 vaginismus, and hyperactive sexual desire disorder. So just touching on hyperactive sexual desire disorder is, if we do MRI images while we are exposed to sexual cues, the brain literally lights up. So that just shows you that low libido can definitely be defined as a medical problem. So there is inhibition of the activation zones, the erotic spots in the brain. So it is definitely seen as a medical problem. So how do we diagnose hyperactive sexual desire? It is defined as a lack or loss of motivation to participate in sexual activity due to either a decreased spontaneous desire, a decreased responsive desire, and the inability to maintain desire or interest throughout sexual activity. And it should be present for at least 6 months, accompanied by distress. We know that about 10% of women in the general population have low libido, but it's much higher in breast cancer, and it can be as high as 85%. And the problem with hyperactive sexual desire disorder is there's hypofunctional excitation. So the exciting pathway is hypofunctional, so it's not working. And there's hyperfunctional inhibition, so the brakes are just too much. So when we look at the dual control model, it's regulated by neuromodulators, neurotransmitters, as well as hormones of the excitatory pathway, as well as the inhibiting pathway. And there's decreased neural activation of the brain regions associated with sexual arousal. And there's lack of disinhibition of brain regions involved in cognitive processing. So how do we treat this? So from a medical side, we can look at the testosterone levels. We've got testosterone that's been registered in South Africa quite recently for treatment of low libido in postmenopausal women. So one can definitely have a look and see if the testosterone levels are low. Then one can definitely, well, not we have to manage other forms of sexual dysfunction and manage any other underlying causes such as medical or psychiatric things. And then we can consider off-label treatments such as bupropion, trazodone, or oxytocin to see if we can really work on that exciting pathway. Bupropion works on dopamine and noradrenaline, and that's got excitation effects as well as oxytocin. So the big question that I've had several times is, what about testosterone and breast cancer? Because we often hear that breast cancer, we can't use estrogen at all, and people are worried about that. But where does testosterone fall in place? So testosterone is the most abundant biological active hormone in women. And we've got androgen receptors throughout the body, including breast tissues, where testosterone decreases tissue proliferation. However, testosterone can be aromatized to estradiol, which increases proliferation and potentially breast cancer risk. But recent clinical data support the role of testosterone in breast cancer prevention. Women with symptoms of hormonal deficiency treated with pharmacological dosages of testosterone alone or in combination with anastrozole had a reduced incidence of breast cancer. In addition, testosterone combined with anastrozole effectively treated symptoms of hormonal deficiency in breast cancer survivors and was not associated with recurrent disease. So this just summarizes that testosterone is safe. It's not going to cause breast cancer, and it is safe to use in breast cancer survivors. Moving over to...
So can I just ask you, Jireh,
Yes.
are you going to be talking a little bit about this new Testofem or supplements, or is that something you'll be touching on later?
No, we can talk about it now. I don't think I've got extra slides on testosterone later on.
Yeah, so we have been using the male androgel, what is it, Testogel for testosterone replacements over the years, but there is a new thing called Testofem.
Yeah, she mentioned it,
yeah. Okay, so and is that your preferred route of testosterone replacement, or what do you normally use?
Yeah, so up till now, we use the compounded testosterone therapies because we didn't have a registered testosterone available. And I think for some doctors, it's still a very controversial topic. Where do we place it? Can we use compounded testosterone or estrogens, even hormones? And I've been using it for years because we didn't have other options. So definitely in South Africa, if we've got a registered product available, we can use it, but the registration for Testofem is only for postmenopausal women. So if it is not a menopausal lady, then it would be used off-label. And then, but for instance, a breast cancer a survivor patient would be in menopause most probably because they are on estrogen blockages, and some of them go for oophorectomies anyway. So they are pushed into menopause, and in that way, we have registration to use it for them, yes.
So do you have experience in using a Jireh in this very important indication in breast cancer survivors? And if so, what is your finding in these women?
Well, I haven't used Testofem itself in breast cancer survivors, but in the past I would have used the compounded testosterone creams, and it works. So in theory, I think either compounded or registered products, testosterone is testosterone. And if we can increase testosterone levels systemically, the patients respond to that. But I always tell my patients that if there's low libido or sexual dysfunction, it's not only a testosterone thing, because there's other inhibiting factors as well. So for instance, if there's sexual pain and we can normalize testosterone, the excitability is going to be a bit higher, but the inhibiting aspects of the pain is going to still overrule, and then we are not going to have the spontaneous desire. So in my practice, what I see with the ladies when we treat testosterone is that it's not going to increase the spontaneous desire, But one of my patients actually worded it the other day, and she said, at least I'm not rolling my eyes every time my husband initiates sex anymore. So, and I thought that is a beautiful way to seeing it, because looking at that earlier model from Rosemary Basson on female sexual function, we need a willingness to become receptive, to allow stimulation. And if the testosterone levels are normalized, hopefully we can just get that going. And I'm not going to roll my eyes. I'm going to be open for it, and I will allow stimulation. And then arousal should be better. And then it's much easier to develop a response of desire.
I understand. Thank you.
Okay. So moving over to dyspareunia. So dyspareunia is pain experienced during penetrative sexual activity. In the general population, we see it anything between 8 to 22%. I feel it's closer to 22%. About 1 in 4 patients or ladies will experience painful sex somewhere in their lives. And obviously, the rates are much higher in breast cancer survivors. It may be superficial, located only at the entrance of the vagina, or it could be deep pain in the pelvic area. Superficial dyspareunia is often given the diagnosis of vulvodynia. And vulvodynia is defined as pain of at least 3 months without a clear identifiable cause, which may have potential associated factors such as hormonal, inflammatory, musculoskeletal, neurological, or psychosocial factors. And when it's localized to the vestibular tissue itself, we define it as vestibulodynia. So superficial dyspareunia or provoked vestibulodynia is tenderness throughout the vestibular area, and it could be hormonal, neuroproliferative, inflammatory, or caused by hypertonicity of the pelvic floor. And how do we evaluate for that? So you are just going to take a moist earbud, and you are going to touch the vestibular area. And we want to see if there's any signs of allodynia, pain to a non-painful stimulus, and or hypopathia, which is pain provoked by very light touch. So what we do is we start with over the inner thigh and the mons pubis, and most patients will not have pain or discomfort there. So I would touch the area with the earbud and ask them, okay, you see this is 0 out of 10 pain. And then I touch different areas with the earbud and ask them to rate the pain or discomfort on 0 being no pain at all or 10 being excruciating pain. So we go through the labia majora, the prepuce of the clitoris, the perineal area. And in the vestibular tissue, we would go at the Skene's glands, which would be around 2 and 10 o'clock position, at the openings of the Bartholin's glands, 4 and 8 o'clock position, and then exactly at the 6 o'clock position, posterior fissure, we will touch that area as well. And then we also want to evaluate the pelvic muscles, and we want to see if there's any trigger points over the levator ani muscles, and see if there's any hypertonicity. And then we can define it as levator ani syndrome, which in the past has always been called vaginismus, although most of my colleagues, we still use the term vaginismus. Often the patients will have urinary symptoms as well, and they can also complain of lower back pain or pain in the hips. So genitopelvic pain and penetration disorder is the persistent or recurrent difficulties for at least 6 months with one or more of the following: the inability to have vaginal intercourse or penetration, marked vulvovaginal or pelvic pain during intercourse, marked fear or anxiety either about vulvovaginal or pelvic pain or vaginal penetration, marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. The problem causes significant distress, and it's not better accounted for by other Axis 1 disorders. And we get different types and classifications. It can either be early onset or lifelong, or late onset acquired genitopelvic pain disorder. Now, looking at this ratio,
Jireh, sorry, there's a question come up for that. Just go back to there we go. Penetration disorders. Somebody wanted to know, is it possible to treat penetration disorders or vaginismus by means of Botox injections? Do you have any experience with that option?
Yes, definitely. So the approach, I'm not sure, I can't remember the slides offhand now, but I think I'll touch on that a bit later as well. But in general,
Okay.
our approach to vaginismus or penetration disorders would be to, if there's vestibular dynia, which there mostly are, we treat the vestibular dynia with a combination of estradiol, a local anesthetic like lignocaine, prilocaine, and a combination of gabapentin, which we apply over the vestibular area to address the vestibular dynia. And then for the hypertonicity, we refer to pelvic floor physiotherapists and use vaginal dilators. And then Botox definitely plays a role there. So in the past, I would have told my patients that we place Botox at the last option. So we start with the physio, use the dilators, and if we don't have results or the progress is just too slow, we can add Botox on top of that. But we are getting to a point where we feel if we can offer Botox earlier, we get quicker results and it's not this long, tedious process. So definitely Botox plays a role.
Thank you.
Okay. So looking at genitopelvic pain disorder and cancer, one of the adverse effects of cancer treatments, especially with breast, uterine, and colorectal cancer, is dyspareunia due to a decline in estrogen levels. A systemic review of 171 studies conducted worldwide found that at least 45% of breast, gynecological, and colorectal cancer patients reported pelvic pain, and it increased to 55% for gynecological and rectal cancers treated with radiotherapy as well. So practical treatment considerations in the management of genitourinary syndrome of menopause was found that atrophic symptoms and signs women may experience in vulvovaginal, bladder, urethral,
Jireh, I don't know if it's us, but we seem to have lost the audio on you.
Jireh?
Hi.
Hello, Jireh?
Yeah.
Sorry, we lost for a minute your audio. Were you back in audio? Thank
Yeah.
you.
Okay, sorry, my connection did something weird. Is everything fine now?
Yeah,
perfect.
thanks. We can hear you beautifully. Thank you.
Okay. So the main thing that we know is that genitourinary syndrome of menopause is a progressive condition that does not resolve without treatment and can adversely affect women's quality of life. So just thinking about menopause, a lot of women's got this thought that if they approach menopause or they go into menopause, they've got these vasomotor symptoms. They experience a lot of hot flashes, and sometimes that goes away by itself, obviously. But the urinary changes and the genital changes that we see is a progressive condition. So the atrophy gets worse and worse and worse over time, and that can definitely affect sexual function. Okay. So this study just also had a look at the different options we can use to manage genitourinary syndrome of menopause. And they said we can both use systemic or vaginal estrogen products that been available, and that is the most important thing to consider as treatment options. And we can also offer vaginal progesterone. Unfortunately, we don't have that available in South Africa, but it can be compounded as DHEA. So for a lot of breast cancer survivors, they are really worried if they hear the word estrogen, although we know vaginal estrogen is safe for breast cancer survivors and we don't see systemic absorption. But if there's a real fear, we can go off label and use DHEA. So adjunctive treatment to basically vaginal atrophy that we see with the menopausal changes resulted as a result of the cancer therapies would be lubricants. We prefer to use silicone lubricants. The problem with the water-based lubricants is it just gets absorbed so quickly. So we start off nice and moist, but then we just need to reapply, where the silicone is a little bit goes a long way. We can use hyaluronic acid moisturizers, offer vaginal dilators for the patients with pelvic pain, and like we discussed earlier, also refer to pelvic floor therapists. So this is just what the dilators look like. In general, we have 5 sizes of dilators, and the smallest one is basically a size of a finger. And the idea with the dilator is they can use it at home. We apply a lubricant over the dilator and advise the patient to insert it slowly into the vagina. And once one dilator going in is not painful anymore, then we go over to the bigger size. And in that way, we start stretching that pelvic muscles. And in that way, we address the hypertonicity. And so this is just,
Jireh,
yeah.
sorry, Jireh, we've just got a question here. Talking about lubrication, which is your preferred lubricant for the use of intimacy and also vaginal dilator use? I suppose you often ask that question.
Yeah, I know a lot of places we are not allowed to brand names, so
no, you're allowed to. We're quite open over here and be candid.
Okay, cool. No, so Pure is a brand that we often advise our patients to get. That's PJUR, and they've got beautiful silicone-based lubricants. They've got different ones, which the one is a medical, I can't even remember exactly how they term it, but one of them is definitely designed for patients with recurring infections or struggle with severe sensitivity. So, but basically any silicone-based lubricant is preferred. I still advise my patients to use silicone-based lubricants on the dilators because, like I said, the water-based lubricants will, once you insert the dilator, it's lubricated, but then the lubricant just gets absorbed. And then you've got this dry dilator that you need to pull out, and that's quite difficult and uncomfortable. But the problem with the silicone-based lubricants on the dilators is that the dilators itself are made from medical silicone. So it actually forms a layer over the silicone and it's difficult to wash it off. But yeah, I still prefer the silicone-based lubricants with the dilators.
So that seems to be the popular one because your colleague at the my sexual health team said we must use something called Assegai, which is also a silicon-based.
Yeah,
but
so
I've got glass dilators, and then they, of course, don't have that problem that you mentioned.
Yeah, so yeah, the dilators that my sexual health uses changed over time. So the first dilators that we got was this hard plastic that almost it's not a silicone plastic. So the silicone lubricants didn't get attached to that. And that's when we started using the Astroglide or the pure silicone lubricants. And now with the new dilators, which is silicone, some of the patients complain that it actually gets stuck to the dilators itself and they struggle to wash it off, but I still feel that it's preferable over the water-based lubricants.
So would you warn against the use of glass dilators if they're hard? Because they're not hard, they are absolutely solid glass. Would you say the silicone ones are more flexible?
It's not really flexible. It's just that the tip itself has got some leeway. And yeah, so if a dilator is a dilator, so if someone's got access to one or the other, I feel that I don't have a preference. It's just that we get the silicone dilators made, and that's what we've got available.
Thank you.
They were quite expensive when I last checked through another company. I mean, yeah, they were like a few thousand.
Silicone dilator.
Well, just the plastic ones that I was actually ordering. I mean, I send these patients to, you know, to
my sexual health
people. Yeah, but I mean, I've tried to get them, and they are quite expensive.
But you buy them off the website, Steve. My sexual health website. You've got them there, haven't you?
Yeah. So I'm not sure about the exact price, but a full set of dilators is over R1,000. One can buy them separately. So number 1 and 2 gets packed together. So you can start off with that. And then sometimes it's not necessary to get a 3 because with the physiotherapist, we got further stretches. And then we would say, rather skip the 3 and go to the 4. So it also depends on the severity of the muscle spasms and the hypertonicity. Some of my patients, I would even tell them not to start with a 1 or 2, start with a 3 and a 4, or a 4 and a 5, for instance, so they don't have to get the full set.
Okay. So yeah, well, thanks. I mean, yeah, these plastic ones are very similar to the ones that you had, were like, I think about 3,000 or 4,000
that's
from another company.
expensive.
So that's fine. I mean, sure, that's not too expensive. There's a
Yeah, no,
question
this is
from
under
Fiona
2,000,
Mason.
a full set.
Yeah. There's two questions from Fiona Mason from Grahamstown. I was speaking to a patient today who said that an O-nut
O-nut.
had made a huge difference to experience of dyspareunia. What is your opinion on this?
If you could just tell us what an O-nut is.
Yeah.
And the second question?
And then the further question from Fiona is, in addition, this patient mentioned that using a vibrator just prior to penetration reduced the inhibition. And what is your feedback from patients on this?
Okay. So just on an O-nut, I wish I could, I had a sample here. So basically, the O-nut looks like a donut, and it's a stackable silicone ring, so it's compressible, and it's got three rings that you can stack on each other. And the idea with that is your partner would put it over the penis, and then it shortens the penis the length. So with penetration, it's not full penetration that happens, but for the partner, the first part of the penis is still covered, and there's some movement because it's squishy. So with penetration, he still has that sensation over that part, but it's only the tip of the penis that penetrates. And like I said, it's stackable. So one can start off with 1 ring or 3 rings, for instance, and then it's only the tip of the penis that penetrates. And then as we progress with the management, we can ditch 1 ring, and then we've got 2 rings, and penetration is deeper. I hope that makes sense.
Yeah.
Okay.
Yep.
Yeah.
And then the other question with regards to the use of dilators prior to penetration. So just ask that question again. What was?
Question from Fiona from Grahamstown was, Steve, just pull it up. It said, in addition to the patient, this woman patient of hers mentioned that using a vibrator just prior to penetration reduces the inhibition. What is your feedback from patients when they use a vibrator?
So I think it also depends on what type of vibrator they're using. So if it's going to be just a bullet clitoral vibrator, obviously that's going to result in arousal. And once there's arousal, there's this response of desire. And because there's arousal, there's more blood flow going to the area. And because you're aroused, all the pelvic muscles just relax, and penetration is easier because you're already in the aroused state. But the other thing that we can also sometimes use would be like a vaginal dilator, or a dildo or penetrative dilator. And a lot of patients would use that just to help stretch that muscles prior to penetration. So we get different shapes and sizes, but the idea then is obviously insert it into the vagina, and then the vibration inside the vagina helps loosen the muscles, and then penetration is less painful.
Okay, thank you.
All right. Okay, so this is just oh yeah, I've got the name up. So here is the
Pure Med.
The Pure Med Premium Glide. That is the brand name of a silicone-based lubricant, but these things have changed so much in sexual health products. So there's different brandings available. So any silicone-based lubricant. And then the Hydra V is a beautiful thing to use for women with severe atrophy because it's a vaginal moisturizer. It contains hyaluronic acid. It's got vitamin A and vitamin E in it. I don't know why it cut off there. And it improves with vaginal moisturization and aid with local tissue repair. So the difference between a lubricant and a moisturizer is a lubricant is to be used during sexual activity and sexual play, or with the use of dilators, where a moisturizer is daily application, and it actually helps restore the tissue itself. So like in all sexual health consultations, I don't know if you guys are aware of the Plicit model. So how do we talk about sex? So now we've got patients coming in, breast cancer survivors, just in general, I think we see patients coming in for X, Y, and Z different things. And often patients have sexual concerns or sexual problems, and they don't know where to go to, and they don't know how to start the conversation. And the PLISSIT model is just an approach to having conversations around sexual function. So the P stands for permission, L is for limited and legitimate information, S is for specific suggestions, and I is for intensive therapy. So just looking at permission, we want to give a patient permission to start the conversation, and we want to have appropriate professional preparation and practice only ethical curiosity. So basically, we can just include it in a general history taking. So we all ask our patients, okay, previous medical history, do you have high blood pressure, high cholesterol, family history, previous surgeries? And then on that list, just in general, we can ask sexual function, how's your sexual function? And that gives the patient permission to say, this is an open platform, we can have open conversations around this. And then we need to have appropriate professional preparation. So there's no point asking a patient about sexual function if you don't have a clue on how to address it. So just make sure you have know the basics, and only practice ethical curiosity. And what I mean with that is maybe a patient comes in and it's a transgender patient, and you are very curious about the type of sexual play that they've got because you're just curious. If it's not relevant to the way you're going to manage the patients, don't ask questions. So the curiosity, it should be ethical, and it should be the questions you ask should be relevant to the way you want to manage the patient. Legitimate information. We want to affirm the possible impact of the diagnosis, medication, and surgical procedures and medical conditions on their pleasure. And we want to respond with scientific evidence and right-based experience-informed information about sexual function and sexual pleasure. So legitimate information is we just give proper information. We know it's backed with scientific evidence. It is scientific, it's evidence-based, it's right-based, and experience-informed. Then we can offer patients specific suggestions. So the sensate focus therapy remains a valuable tool. I don't know if you have come across the sensate focus therapy. I feel it's sex therapy 101. We throw it on any sexual dysfunction. And the principle behind that is we would say penetrative sex is off the table, because the problem that most people have with sexual dysfunction is I can't have sex, or I'm not interested in sex. And because of that, they avoid all forms of intimacy, because any touch or stimulation or just a cuddle might trigger thought that your partner wants something else. And already then you're backing off and you're not willing to become receptive. And then we can't follow Rosemary Bassin's response. So the sensate focus says penetrative sex is off the table, but we want to focus on sensuality. And we take turns to schedule appointments, because planned intimacy is better than no intimacy at all. And the giving partner would start off just with giving a back massage, for instance. And the next session, we will switch the roles and the other partner will give a back massage, but it stops with that. And afterwards, we talk about what was beautiful about it, did I like, and only positive feedback. The next session could be a bit more sensual, kissing involved. The next session, we add genital touch, etc., etc., etc. And if we do that while we're managing at the sexual dysfunction itself, for instance, we refer the patient to a physio, we start with the dilators. By the time we work through the sensate focus therapy and they're ready emotionally maybe for penetration, physically we have made good progress with the pelvic floor as well, and it's just in a good place. The other specific suggestions we can just give patients would be things like just a basic vocabulary to enhance sexual experiences. And we don't need big, fancy, sexy words. We can just say harder, softer, up, down, left, right. So we don't need this extravagant sex talk. Intensive therapy would refer to more intensive therapy with regards to regards to sexual dysfunction itself. So then we look at medical treatments, looking at hormonal therapies. When we use hormones, we don't want to use estrogens that can increase your sex hormone binding globulin, because in that way it will bind to your testosterone. We can use estradiol vaginally, especially if there's genitourinary syndrome of menopause. We can use transdermal testosterone, but I feel it's important to monitor the testosterone levels. We can use neurochemical modulators such as bupropion or low-dose trazodone or oxytocin. And then there's some studies to suggest PDE5 inhibitors for women that have peripheral acting effects to assist with arousal, although the data is a bit sketchy and not fully out there. Then we want to refer to a physiotherapist if there's pelvic floor dysfunction, and then one can offer regenerative therapies such as laser therapies or platelet-rich plasma. And if you're stuck, rather refer the patient and send to the right place. So in conclusion, breast cancer is very common. We've got high survival rates, and the quality of life is thus very important and crucial. Sexual dysfunction is very common breast cancer survivors. That is because of the biological impact of the treatment itself, the psychological aspects, as well as the social problems. And so if you've got a breast cancer survivor in your rooms, rather screen for sexual dysfunction. And if you can't assist the patient, refer to the right place. And that's it. So I don't know
Thank you
if
once
there's
again,
more-
Jireh. It's a wonderful talk. We thoroughly enjoyed your presentation, and we had well over 100 people logged in this evening. Shows you how important the topic is and how important it is for us to be comfortable with the topic. Steve is going to thank you. I'd just like to ask you about the role of laser therapy. Steve, would you open the questions on laser therapy?
Yeah, I noticed you didn't mention laser at all for these patients. I've had a laser machine in my office for almost about 7 or 8 years, and I do regularly get patients referred to me for this the breast cancer survivors particularly. And it's a nice non-hormonal option for these patients with relatively good responses in a lot of them. And I know we did have a talk from Tuve de Villiers about 3 or 4 weeks ago, where he did quote one abstract from one of the journals to say that there were some questions regarding its efficacy regarding a RCT that was done. But you know, anecdotally, and also a lot of observational studies showing that it really works. But I was just wondering what your thoughts, did you have any experience on this, and what is your general feeling about it?
Do you have access to laser therapy in Serfontein? Is it no?
No, so I think that's, you don't know what you don't know. So I know laser therapy is available, and I know there's studies to support the use, but then there's other studies to say that the data around it is not very strong data. But I feel that if it's a safe option, I always tell my patients when I approach something, I try to practice ethical medicine. And if we look at the ethical principles that we stand on, we look at beneficence. So can it be beneficial to the patient? Yes, possibly. Maleficence, is it going to cause harm? Probably not. And then autonomy, let the patient make their own decisions. So we want to encourage evidence-based medicine. And I actually, to tell you the honest truth, I haven't taken the time to read up too much about it. So I don't know if we've got very strong evidence to support it, but it's not harmful. And then I think it is an adjunctive therapy or option that we can offer our patients.
Well, we're fortunate, Steve, to have you that does laser therapy and Botox. So for vaginismus and other dysfunctions, pain, vulvodynia, which I think that might be helped by women, then it's wonderful to have you as a referral base.
Yeah, no, look, I mean, so I think it's maybe, in my opinion, quite underrated, having you know, used it quite a lot. But
Laser or Botox?
well, the laser.
Laser.
I don't do a lot of Botox, but I do a lot of laser for patients with dyspareunia, and it has changed a lot of patients' lives, and from sort of sexual function point of view. You know, and if we think about the very wide use of laser in the cosmetic clinics and for skin rejuvenation and skin, you know, resurfacing, etc., you know, it's a very similar type technology. So, you know, and it is certainly an option, because, you know, you get those patients who just don't want a hormone, you know, try as you may to reassure them, they just don't want it. And I think that is a role. But I mean, I always offer them the hormones first. And it's
Oh,
not,
Vagifem is
yeah.
very, very safe, even in breast cancer survivors, I think.
Yeah,
And
it is.
many people use it for that, and it prevents the GSM and also prevents recurrent UTIs. So we're very keen on that
But
stuff.
Pete, on that point, the buying from some of the oncologists is one of the problems. And, we find that, with many things in medicine, things take their sort of place in the hierarchy, and, a lot of people will be very happy to have, survived the breast cancer, survived the chemotherapy with maybe less side effects than they thought they would get to. But, they won't often discuss this with their patients. So I think we need to possibly be liaising better with the oncologists. This is something that isn't widely discussed, and a lot of them are still very against the vaginal estrogens.
Yeah, well,
I was
laser is an alternative that you should explore
that's
that we
not-
do use.
But
Yeah.
that's not the point. The point really is just that, the estrogens are safer than we might think. And a lot of them are just often blanketly saying to the patients, no hormones. But
Yes.
it's not maybe really in their best interests.
Yeah.
So, I think it's something that maybe needs to be addressed at that level.
Okay, Jireh, it's almost 6 o'clock. We're running out of bandwidth. We get shut down at 6, so we don't want to suddenly go
We
blank.
don't want you to turn into a pumpkin.
No, you won't turn into a pumpkin, Steve. Don't you worry. You'll turn into a turnip. It's been wonderful having you, Jireh, and we hope that everybody logged on over here, the hundreds of people that have logged on, will be with us again next week, because we have air travel in pregnancy. If you're pregnant, should you fly or not? That's basically what it is, because we have very large numbers of women that do air travel in pregnancy for all sorts of reasons. And is it safe or is it not safe? I know the answer, but I'm not going to tell you what the answer is, Steve. Do you
I'm
think
looking
it's
forward
safe?
to it.
Air
Well,
travel in pregnancy?
Well, I've flown many times.
No, but
pregnant
we're
people.
talking about pregnant women, not you.
No. Well, I think it's safe, but I'm looking forward to hearing the answer.
Yeah, well, air
yeah.
travel in pregnant
Actually,
women.
yeah.
I'm not talking about air travel. I'm talking about air travel in pregnant women.
No. I think it's safe.
Well, Professor
let's see,
Jacobson
let's
is
see.
somebody, he comes
Let's
from
see.
Pretoria as well.
But it's worth the talk, so maybe it's not safe.
No, it's worth a talk. He comes from your neck of the woods. Did you know that, Jireh? Professor
No.
Jacobson, the east of Pretoria. Yeah, the east of Pretoria, where you are. He hails from those areas. You've not heard of him yet?
No. So I'm
No.
definitely logging in next week.
That'll be wonderful. So that's that. And then, Steve, I'd like to thank you. I'd like to thank Chris, our technician, for being, and especially in a special warm thanks to Jireh Serfontein, sexual health counselor and practitioner in the east of Pretoria, for your time, your trouble, and for that beautiful presentation you gave us. Thank you then, Jireh, and thank you, Steve, and thank you, Chris.
And thanks to Pete, and thanks to everyone for logging on, and we'll see you all next week to get the answer to
Same
this
time,
very
same
good
place.
question. Yeah.
And of course, Steve, it'll be wrong of me not to thank you for the use of your mini bar when you
Fine.
slipped out.
Thanks for bringing the ginger nuts today. Actually, it was
No, it's a
very
gift.
nice of you. Thank
It's a
you.
gift
Thank
from
you
a
very
rep,
much.
Steve, so I
Thank
cannot
you
say.
so much.
It's a gift
All
from a rep.
right. Thank you so much, and we'll see you all next week.
Jireh,
God.
thank you
Thank
once
very
again.
much. Thank you.
Thank you. Cheers.
Bye.
Bye.